My name is Dr. Neil Iyengar. I'm a medical oncologist at the Winship Cancer Institute of Emory University, where I serve as the co-director of breast medical oncology and director of cancer survivorship services. We're here at the San Antonio Breast Cancer Symposium in 2025, where a lot of exciting new data is being released, particularly as it relates to the management of HER2-positive breast cancer. And I'm delighted to be joined by my friend and colleague, Dr. Martin Dietrich. I'll let you introduce yourself.
Hello, thank you so much for having me. I'm excited to be here. I'm Martin Dietrich. I'm a medical oncologist with the U.S. Oncology Network and the University of Central Florida in Orlando.
Wonderful. So, Martin, let's start by laying some groundwork. Could you briefly summarize CLEOPATRA and essentially the current standard of care and the first-line treatment for metastatic HER2-positive breast cancer?
Dual inhibition of HER2 with trastuzumab and pertuzumab and underlying chemotherapy backbone self-limiting with a taxane. This has been the standard of care for over a decade and really has not only given us an improvement overall, but a continued improvement with each long-term time point. So the dual inhibition of HER2 was really a long-standing standard of care for our patients. We've seen the curves dividing up further. There was an initial concern, but obviously the longer we moved out, the more we learned about this. And we think about some of these responses as really durable and maybe permanent. So quite a leap forward compared to where we were before treating HER2-positive breast cancer. But it's always nice to see new data evolving. So I'm looking forward to the discussion.
Yes, absolutely. Well, and I caught how you mentioned the current versus past standard of care because the landscape is changing so quickly. And before we get to some of the new data that you alluded to, I think we certainly acknowledge the incredible impact that CLEOPATRA has had, especially with the 8-year long-term follow-up data. But I want to ask you about current unmet needs, or at least with the CLEOPATRA paradigm. What do you see as the pressing unmet needs in the care of our patients in this setting?
Well, I think there are a number of factors. I think one is the durability. We've had about 18 months progression-free survival in CLEOPATRA. I think there is a question about durability in these young patients. That is an important one. One other factor is always brain coverage. Obviously, the disease is highly prone to intracranial manifestation. So having coverage here in dual ways is very important. And obviously, developing subsequent line of therapy standards that will be able to sort of extend the benefit that we're seeing. And obviously, with DB01 and DB03, we had some data that really heralded that we have post-progression therapy that's able to overcome some of the resistance that we're seeing. The HER2 amplification is a very stable genetic alteration, so this remains a potential target all through the course of those treatment lines. So I think those were the main ones. So I would say durability and brain metastases are probably the two pillars that I would like to work on the most.
That makes a lot of sense, absolutely. And I think that diving a little deeper, what are your thoughts about the management of adverse effects or areas of need there? I think the CLEOPATRA regimen, we certainly deal with the toxicity of taxanes, and really, of course, any therapy has toxicities that we need to manage. But how has this impacted your patients in terms of the duration of therapy and how that translates to toxicities related either to the taxane or to the regimen as a whole?
Yeah. I mean, obviously, it's a self-limiting regimen. The neuropathy is clearly impactful, and the longer you think about survival, the more pressing the issue seems that we really have to cut back and cut out with taxane backbones. The other question is GI toxicity, especially with pertuzumab. I think that has always been a discussion for us, how well we can manage this. I think there are other side effects that we monitor, but I've gotten quite comfortable with contractility of the myocardium as a sort of an on-target effect of HER2. I think that's important. But I think overall the regimen was pretty well tolerated, especially as it moved into the maintenance space. So it was definitely a leap forward for us.
Absolutely. I think your point about neuropathy is so critical. I find that oftentimes our discussions regarding when to stop the taxane is both a mix of response and tolerability. And on that same vein, I think thinking about the how robust the response is. So are we achieving a complete response? Are we achieving a partial response? In my experience, it's oftentimes a partial response where we decide to stop partly because we've achieved a response, but also partly because of toxicity. What has been your experience in terms of response to THP? Have you seen a lot of CRs? I certainly think that this is an opportunity for improvement, but curious in terms of what you're seeing.
Yeah, I think that's part of the challenge that we have, because we have a lot of patients over the years that have long-term durable responses to HP. But we forget about all the patients that have progressed on therapy initially. So the anecdotes of the long-term responder really makes us look at the regimen sort of at the very emotional eye. I think this is clearly possible. And I've had patients, and I think an individualized discussion where we stopped HP, where we felt this was so deep of a response, where we had both imaging negative, and I like to use a lot of ctDNA and ctDNA negativity at the same time, that we even stopped HP. I think we can cure a certain subset of HER2 amplified breast cancer. But the question is it the majority of patients? And it's clearly not. We have a durability. I would like to go as deep into deep of a response as possible, but we oftentimes really limit it, and there's some intrinsic resistance mechanisms that we have to account for as well. So it's a really a big clinical judgment balance.
Well said. Yeah, I think your points, you've made so many interesting points here, and we're in an interesting phase right now where we're de-escalating therapy, but we're also escalating therapy. And I think about it in terms of getting back to your point about maintenance therapy, induction and maintenance therapy, and perhaps if we're strategic about where we escalate therapy, or at least where we use more effective therapies, then perhaps it'll set us up for more successful either maintenance or even the curative approach that you alluded to, the elusive curative approach. And I think trials like the Stop HER trial and ongoing trials in that vein will be helpful in terms of addressing whether or not we can achieve that. But for now, I think that successful induction is really critical. And for a long time, the successful induction regimen was indeed CLEOPATRA, as you've been discussing. But let's move to more recent data that you've been alluding to, and certainly DESTINY-Breast09 was a game changer in terms of what we see in the in terms of tumor response and the induction setting. Could you walk us through DESTINY-Breast09 and your thoughts about how these new data may be incorporated into the new standard of care?
Absolutely. So DESTINY-Breast09 was a global phase 3 study, a 3-arm randomized study that looked at comparing our previous standard of care, THP, against 2 arms, one trastuzumab deruxtecan and a second intervention arm with trastuzumab deruxtecan plus pertuzumab, which is the one that is probably going to be the one most practice-changing once approved, where we looked at our standard of care in a very fair and objective way, enrolling patients of the full spectrum, hormone receptor positive, hormone receptor negative. Patients with brain metastases were allowed in this clinical trial as well, and compared those two. I think there was a signal from DB01 to DB03 that we would see the cross-trial comparison, probably a favorable response, but the data came in probably even better than I had expected. So we saw over 3 years, 40 months of median progression-free survival. Surprisingly, the THP arm did quite a bit better than it did in CLEOPATRA. We saw about 28 months, about a year median progression-free survival positivity. I think the benefit extended across all subsets. I don't think there was one that particularly benefited. We saw it for hormone receptor positive, hormone receptor negative. Clearly a signal that we appreciated was in the brain metastatic population. I think T-DXd more and more recognized with specific data, but also the correlative data from clinical trials that this is a highly brain active agent. So a lot of excitement about this. I think the discussion came a little bit about the idea of comparing some of the durability of T-DXd. Obviously, it's a chemotherapy-based antibody drug conjugate. So giving this continuously, almost for 3.5 years, was sort of daunting for some. I think this is going to be a discussion we're going to be having with our patients in the clinic.
Absolutely. Well, that was a really nice summary of the data. Thank you for walking us through that. And I think we'll certainly get to the question of duration of therapy and perhaps some strategies that we could employ there. But, I think it's interesting because for so long, CLEOPATRA has been the standard of care. And I think, in designing trials, we used to joke that we don't want to go toe-to-toe with CLEOPATRA because the bar is so high. But it is remarkable when we think about our patients that despite the success of CLEOPATRA, still a lot of room for improvement. And patients do, unfortunately, continue to progress and succumb to the disease. And to see a new regimen, T-DXd plus pertuzumab, after more than 10 years of CLEOPATRA as the standard of care is really a shift in the field, a major shift in the field. But let's talk about how you might implement this in your practice. In terms of patient selection, how are you thinking about which patients that you'll offer T-DXd plus pertuzumab to in the first-line setting?
So it's a difficult discussion. This was an all-comers trial by evidence-based approaches. I should probably offer this to every patient. I do think about a couple of patients as particularly high risk, obviously patients with brain metastases at baseline, hormone receptor negative patients. I think they have a worse prognostic outcome. They have more challenging disease to expect prognostically from the beginning. So there it's a clear cut. I'd probably expect that this applies most intensively in these subset. But when I look at the data for hormone receptor positive disease in patients that did not have brain metastasis at baseline, they did benefit in a very strong fashion as well. So it's very hard to slice these patient populations into subset. It was an all-comers regimen with an all-comers benefit. So for efficacy purpose, and this is a discussion we have to have with our patients, what are the goals of our treatments? And if efficacy is the outcome that we want to look for, it's very hard to see that we're not seeing the arrival of a new standard of care first line. It's always difficult to see this degree of change. Obviously, it's a very established practice pattern to use THP, but I think we're there. I think this is what's happening.
Absolutely, and just to dovetail off of your comments, you had also alluded to the efficacy of T-DXd in the second-line setting and beyond. And a couple of years ago at ESMO, we saw some interesting pooled analyses of the various Destiny breast trials, which indicated in multivariate models that more upfront use of T-DXd is associated with better disease-specific and long-term outcomes. And that was pooled analyses, but now we have proof of principle and confirmation, I should say, in a phase 3 global trials setting from Destiny Breast 09. So what are your thoughts about colleagues who may say to you, well, we're so used to using CLEOPATRA in the first-line setting, and we have T-DXd approved in the second-line setting. Do you think that's a reasonable approach to stick with that kind of second-line use of T-DXd, or are you compelled by DB09 to move T-DXd and pertuzumab to the frontline, first-line setting?
I think it is clear that T-DXd is a strong agent in second line and beyond. I don't think anybody disputes this. But if you look at the length of PFS, it is clearly declining. Not sure if it's a function of tumor biology or a function of patient's constitution or both. But the biggest impact we achieve in the first line setting compared to CLEOPATRA, clearly the doubling of the expectations. So it's very hard to ignore a year plus progression-free survival benefit and not make a decisive change. I still think that patients that are currently on THP are very well served at the DB03 second-line regimen, but it's clearly concerning that we're seeing patients not transitioning to second line. It's obviously not as many as in some other disease spaces, but in the HER2 amplified disease, patients that will develop brain metastases, I think we're going to see similar results like we do in other disease spaces where T-DXd is both active against brain metastases as well as secondary preventing brain metastases as well. So I think those are all important factors. So my principle is always best therapies first, and clearly in the side-by-side randomized comparison, we see here a change in best line therapy. So for me, very hard to stick on. I understand the concept of routine and habit, but I think when we have phase 3 data and we're practicing evidence-based medicine, then we sort of have to adopt that.
Absolutely. I couldn't agree with you more. And I certainly share your sentiments of we need to use our best therapies and our best strategies up front. I sort of see it as a proactive versus reactive approach, which kind of encompasses the important comments that you were making. I think we're more likely to be successful if we are treating patients upfront and preventing the acceleration of the disease or the development of CNS metastases rather than kind of chasing our tails and trying to do that later. Although if we are in that scenario and we do need to do it later, we have evidence, as you said, to support that as well. So I think those are really useful comments about why we do need to be using our best therapies up front. Now let's shift to how you would talk about this to patients. we know that there are adverse effects associated with both the CLEOPATRA regimen, we talked about the neuropathy, but also with trastuzumab deruxtecan. How do you frame the risk versus benefit profile to your patients?
Well, I think if I look at the data with this length of follow-up, the side effects that both regimens provide are included in the data. I don't think that you can really separate efficacy data with the feasibility of delivery. And while we are looking at side effects of cumulative bone marrow toxicity, fatigue, ILD pneumonitis, this is included in the data. And despite the fact that we see these side effects occurring, we still see this tremendous progression-free survival benefit. So it's very hard for me to not think of this as a favorable risk-benefit ratio for patients. And again, it depends what the patient's outcome is. My experience is those are younger women typically, oftentimes with very little comorbidities, where efficacy and survival is really what they're asking of me. And then the discussion is very clear. We have a new standard of care by efficacy standards, which doesn't mean that THP is not a legitimate regimen for a patient that opts for a sort of a more gentle approach. But again, most of my patients tell me in their own words that efficacy is what they're aiming for, and then the answer is very clear, and there's not a lot of decision-making necessary because the trial gives us the answer.
Absolutely. And I think that we can be proactive, right, about managing the potential adverse effects. Let's talk a little bit about that. You mentioned several of the adverse effects that were noted in DESTINY-Breast09, but fortunately, we're all familiar with trastuzumab deruxtecan, and so we have effective management strategies. What is your approach to either preventing and or treating any nausea or vomiting that may be associated with T-DXd?
I think like we do with any other regimen that's highly immunogenic, I think this is probably one of our strong suits in oncology, supporting patients through GI toxicity. We use steroids, we use a long-acting NK1, we use the 5-HT3s, and then individualize it to patients' needs. I haven't found it to be a problem in my practice, so I've been very proactive about it, and I think that's how the guidelines place the regimen as well. I think there's the flip sides of having highly effective therapy that we need to deliver and supportive care at the same time, but I think that's never been an issue for us.
Yeah, absolutely, and I think that the 4-drug or even 3-drug regimen for nausea prophylaxis is incredibly effective in the same way as you alluded to that we manage nausea for other therapies like anthracyclines. Any pearls that you have about managing either fatigue or any other AEs that are commonly seen?
Yeah, fatigue is obviously more challenging, and we have to differentiate the fatigue that is related to anemia versus the fatigue that's related to and that's sort of a non-anemia related. My experience is that eventually we cut beta doses down. So the 5.4 milligram per kilogram starting dose we talked about, achieving a really deep response in the beginning, moving into a higher level of time frame where 4.4, even the 3.2 milligram per kilogram body weight dosing may be necessary. I think we strike a balance there between efficacy and safety. I don't really perceive a big efficacy loss when we dose adjust, and obviously we're running a long marathon here for the treatment paradigm. So fatigue, obviously, I encourage, and I think this is your special area of expertise, lifestyle, exercise, very, very helpful in changing brain chemistry, more so than any medication that I'm aware of. So 4 times a week, rigorous exercising, being as active as possible. I think those are important factors.
Yes, I love that. I love that you said that, and I think dose reduction is certainly a tool that we can use, but I always like to refer to the preferable effect trial in the metastatic setting, which validated a lot of what you just said in terms of exercise significantly improving patient-reported fatigue. And so I think that from a quality of life standpoint, this is certainly a manageable regimen. Let me ask you, as we think about individualizing therapy, when you use the DB09 regimen, are you treating to progression, or are there other strategies that you're deploying for the use of T-DXd and pertuzumab in the first line?
So I followed the clinical trial protocol. So disease progression, unacceptable toxicity or if the patient opts out. And we're flexible. The patient is in the driver's seat if they need to take a break, if they want to travel. We're not bound by the every 3 weeks the cycle. We can extend this and be flexible in adjusting this. And oftentimes these deep responses, in my experience, last very long. So I'm going to have patients that, for whatever reason, interrupt for 6 to 8 weeks. They see no change. Look, a lot of ctDNA in my practice. So I think this is something that we handle as part of the practice of medicine very flexibly. There are strategies that are looking at de-escalation strategies. I think they're very early. I think they're not ready for practice or prime time. So I try to discourage something that I would like to do, which is to de-escalate from actually implementing it when I don't have any good data set to support it.
Yeah, I think that's very fair. And as we start to see more maintenance strategies coming out that are typically using the THP induction regimen, I think we are starting to think about what is the most successful induction strategy, and certainly the response rates for T-DXd are quite compelling, but stick to the trial and stick to the data. A common theme that I often hear is what do we do after T-DXd? And I think, in my mind, I frame it such that we're really optimizing the disease state, going back to our conversation of using our best therapies up front. If we can hit the disease with a bang and induce the best response possible, I see that as really optimizing the disease state for subsequent lines of therapies when progression does happen. What would your counsel be to a colleague who is concerned about subsequent lines of therapy?
I think that's a legitimate question. We're changing the entire disease space by moving questions around. For me, I'm more pragmatic when it comes to decision making. I have to make a decision about the best therapy at any given time. So when I'm at the point of decision making before first-line therapy, clearly T-DXd is the most efficacious regimen. When it comes to progression, I do have to extrapolate. I know that there are many drugs available, none of which have been validated post-T-DXd. So it becomes a little bit more and more challenging, and I would individualize it. And this would also be a great opportunity for a clinical trial. I think if it's brain metastatic patients, I think a tucatinib-based regimen would be of great interest. But I think any other therapy afterwards hasn't been really validated. Obviously, T-DXd is going to push that question far into the future, and we will have more insights by the time that this progression happens. And obviously, also molecular sorting might help us select the most optimal therapy.
Wonderful. Well, I think we're fortunate to be in a place where we have a lot of new therapies in the pipeline, and I think that will certainly help us in the later lines of therapy. Well, I want to thank you for your discussion today. I think those comments were incredibly insightful, and I've enjoyed our conversation today and look forward to continuing the conversation.
Absolutely. Thank you so much.